So now we're going to do Chapter 18, Gastrointestinal and Urologic Emergencies. When we talk about gastrointestinal emergencies and urologic emergencies, we're talking about the organs within the abdomen. The way these will likely come in is as a complaint of abdominal pain. The problem we have is that it really takes, x-rays and MRIs and imaging to tell us where the complaint lies. So as an EMT, we don't really need to understand the exact cause, but we need to recognize when it becomes a life threat. The abdominal cavity contains multiple organ systems. So you've got the gastrointestinal system, so the digestive system, the genital system, and that is your sex organs, and then the urinary system, so the removal of waste and liquid. Our solid organs are the liver, the spleen, the pancreas, the kidneys, and in females, the ovaries. When you have injury to a solid organ, you need to expect a significant potential for shock and a large amount of bleeding. Your hollow organs are the gallbladder, the stomach, the small intestine, the large intestine, and the bladder. The problem with hollow organs is that that damage to the hollow organs can cause leakage of the fluids that are in there, which would then contaminate the abdominal cavity and cause both irritation and potentially infection. If you cause damage to the bladder and it's full, you're going to leak urine into your abdominal cavity. Damage to the stomach, you're going to leak stomach acid into the abdominal cavity. So obviously these are issues as well. This kind of gives you just a picture of where the solid and the hollow organs lie within the abdominal cavity. So the liver is actually right there up against the diaphragm, as is the stomach. And remember, based on anatomy and physiology, that you're looking at about 5 feet of small and large intestine winding through the abdominal cavity. The gastrointestinal system is where we'll start, and this is responsible for the digestion process. It starts at the mouth as the food is chewed and saliva begins the breakdown process. Once it is swallowed, food then goes down the esophagus and into the stomach. And this is, of course, the main digestive organ. And remember, it's a hollow organ. The liver, a solid organ, supports digestion with the secretion of bile that helps to digest the fats. It's also going to help filter toxic substances that might have been ingested. The gallbladder, which isn't a necessity to have, is a reservoir for bile. So, if the liver is not functioning at a high enough level, the gallbladder will release bile instead. The small intestine, or the duodenum, contains, that's the top part of the small intestine, contains digestive juices from the pancreas and the liver, and they are then going to mix. What your pancreas releases is the amylase, the bicarbonate, and insulin, and these help break down the different pieces of food and the different particles within the food. The pancreas, because it releases the insulin, is a very big necessity for prevention of diabetes, and it's normally where you're going to find failure in your diabetic patients. The jejunum, or the lower part of the small intestine, helps absorb digestive products, and it does most of the work of the small intestine and the absorption. The ileum, that very last part of the small intestine, absorbs nutrients that weren't absorbed earlier, so it's kind of that last resort for absorption. And then it also absorbs bile acids so that they can process back to the liver for use in the future. And vitamin B12 also for making nerve cells and red blood cells. From the small intestine, we go to the colon, or the large intestine. Food in here is not broken down. The colon's going to receive the things that didn't get absorbed or broken down in the small intestine. We talk about how food moves through, and it's a process called peristalsis. Peristalsis is kind of a wave-like motion that occurs without us having to think about it. And if we had to actually think about digesting our food, just like if we had to think about breathing, we'd never do it. In the colon, water is absorbed, and because this is the food that wasn't absorbed, this is where your stool is formed. So also a part of the gastrointestinal system is the spleen. The spleen actually doesn't have a digestive function though, even though it's considered part of the system. And it's actually part of the lymphatic system. So the lymphatic system helps in the fight of disease, the red blood cell development, and the antibodies. So if your spleen is a reservoir for blood and develops red blood cells and is also a solid organ, consider the impact and the high risk for bleeding if you have a traumatic injury to the spleen. Obviously, we're going to have two genital systems, the male and the female. These are the parts of the male system, the testicles, the epididymis, the vas deferential, or the vas deferens, the seminal vesicles, the prostate, and the penis are all parts of the male reproductive system. In the female reproductive system, you have ovaries, again a solid organ, the fallopian tubes, the uterus, the cervix, and the vagina. The urinary system controls the discharge of waste materials from blood by the kidneys, and the urinary system is going to be for the liquid waste. You have two kidneys. They are posterior, but still considered part of the abdomen, but they do sit towards the back. They're going to help regulate acidity and blood pressure, and they're going to filter the blood. So they're going to pull the toxic waste from the bloodstream. And because they're filtering the blood, there's a high blood flow into the kidneys, and there's a significant risk for bleeding when you have a kidney injury. It's also why we talk about if somebody, like in football, someone has a hit to the back in the lower quadrant, we're going to tell them that they need to make sure that there's no blood in their urine for the next couple of days, that they may bruise, but a big problem will be if they pee blood, because that means that there's probably a problem in the kidneys. The ureters join each kidney to the bladder. So you have two ureters, a right and a left, and then they are going to connect to the bladder. And the bladder is going to be located just behind the pubic symphysis, which you remember from the trauma head to toe. There's no bad touch there. And it's going to empty approximately 1.5 to 2 liters of urine per day. And it does this through the urethra, which travels from the bladder and allows that urine to empty outside of the body. This is kind of a picture of the urinary system. You can see the two kidneys and the ureters traveling to the bladder. And then this is obviously the male urinary system. You notice the prostate gland there. When a patient has an enlarged prostate, it's going to impact their ability to empty their bladders. So let's look at some of the reasons why we might have some issues. And it starts with the fact that the abdominal cavity is lined by what we call the peritoneum. This also covers the organs. So you've got a parietal peritoneum, which lines the abdominal cavity. So parietal peritoneum lines the abdominal cavity. And then the visceral peritoneum covers organs. When you have foreign materials and foreign substances in the abdominal cavity, whether it's blood or pus from an infection or bile from an injured hollow organ, you're going to have irritation of the peritoneum, and this is going to cause peritonitis, inflammation, which is then going to cause problems. Acute abdomen, just like any other time we mean acute, means sudden onset, refers to the sudden onset of abdominal pain. And normally when you have sudden onset of pain, it indicates that there is a severe, sudden, and rapidly developing problem. As I said, peritonitis is inflammation of the peritoneum, which then normally causes ileus. All these new words. So if you have peritonitis, you increase your risk of ileus, which is paralysis of the muscular contractions. So if my muscles can't contract, I'm then not allowing peristalsis to occur. I'm going to retain gas and feces, which is going to cause distension. And instead of the stomach emptying into the intestines as the normal digestive process goes, the stomach, which needs to empty, is going to empty through vomiting. Diverticulitis is another issue that we see patients have. And this happens when you have inflammation in small pockets of weak areas in the muscular walls of your intestines. And then another issue that we'll have patients complain of is what's called cholecystitis. And this is inflammation of the gallbladder. And this is normally caused by gallstones. We have two types of nerves that supply the peritoneum. And when we have two types of peritoneum, remember the parietal is on the abdominal nerve, on the wall, and the visceral is over the organs. We're going to have to consider the types of pain response that we're going to experience as a result of these nerves. So when the parietal peritoneum receives the nerves, they are actually the same nerves that are in the skin. So just like nerves in any area of the skin, those nerves are going to perceive pain, pressure, heat, cold, touch. So they're going to respond differently and send different messages. The nerves that serve the visceral peritoneum are supplied by the autonomic nervous system. As a result, what we end up getting when these nerves are firing are what we call referred pain. So it's pain experienced in another area of the body as a result of pain in the abdomen. If you've ever had laparoscopic surgery, they'll talk to you about after the gas is being reabsorbed, having referred shoulder pain. And that's because the nerves, those visceral peritoneum nerves, are shooting messages in other places in the body. So this kind of gives you that picture of what's happening. You've got the gallbladder, and the nerves of the gallbladder are going to send a message, which then ends up shooting pain into the shoulder or pain sensors in the lower abdomen. So that's going to make it a little harder to understand where the pain is. Some of the reasons that we'll see a patient complain of sudden onset pain in the abdomen, one is ulcers. So ulcers form when you have an erosion of the mucus that protects the intestines and the stomach. And this is then going to allow some acid to eat into the organ. As a result, you may have gastric bleeding. If they are given enough opportunity, and the ulcers may heal without intervention. But normally, if they're untreated, it will cause significant issue. Another form of an acute abdomen is gallstones. Gallstones form in the gallbladder, and if you remember from an earlier slide, the gallbladder stores the digestive juices and waste from the liver. And so when the gallstones form in the gallbladder, they can block the outlet so that the digestive juices and the liver waste can't leave the gallbladder and can't be removed from the body. This will cause pain and lead to cholecystitis, which is inflammation of the gallbladder. Pancreatitis is our third cause of an acute abdomen. And because you see that itis, you know that it means inflammation, and it's inflammation of the pancreas. This can be caused by many things, including gallstones, alcohol abuse, or other diseases. Some of the signs and symptoms that you're going to see are pain in the upper left and right quadrants, nausea, vomiting, and abdominal distension. If it is bad enough, if the infection is bad enough, your patient may actually end up in sepsis, which you know is kind of a full infection, or a hemorrhage may occur. Fourth, we'll look at appendicitis. So the appendix is that little area on the intestine that we're really not sure what happened. We think because of evolution, we no longer need it. But because it's there, if it gets infected and inflamed, it can cause significant issues. Patients who have appendicitis are going to present with nausea, vomiting, possibly they haven't eaten for a few days, fever, chills, and what we call rebound tenderness. So the appendix is in the lower right quadrant, and our patients who are having problems with the appendix, when we push down on that quadrant, they won't experience any pain. But when you release from pushing down, they will have a significant increase in pain. It's called rebound tenderness. Gastrointestinal hemorrhage, so bleeding in the gastrointestinal tract, internal bleeding in the intestines will cause an acute abdomen. Our problem exists is that it can actually be a chronic condition, so bleeding that's happening over time in small amounts, but once it hits a certain level of pooled blood in the gastrointestinal tract, you may have a sudden onset of pain. Esophagitis, it occurs when the lining of the esophagus is inflamed. This may be because of infection. It could be because of chronic acid reflux, where the stomach acids are coming back up into the esophagus. We're going to have patients who complain of pain when they swallow, heartburn, nausea, and vomiting, and they may have sores in their mouth. And then another one in the esophagus is esophageal varices. Esophageal varices occur when the capillaries that line the esophagus start to leak. So you're going to have kind of an oozing of blood into the esophagus. This is going to cause fatigue, weight loss, jaundice, anorexia, edema, and abdominal pain, because as that blood leaks, it is going to be entering the digestive system and the gastrointestinal tract. Mallory-Weiss syndrome is the issue that happens when the connection between the esophagus and the stomach tears. So now you've got food and stomach acid leaking into the abdominal cavity. Your primary and principal symptom is going to be vomiting. And of course, that's bad because since there is a tear, you will get the patient externally vomiting, but some of that is actually, again, going to end up in the abdominal area. And then gastroenteritis. So gastroenteritis is an infection that happens when into the intestinal tract, but it can also just be a viral organism. What our patient will complain of is diarrhea. And if it's happened for long enough, gastroenteritis can lead to dehydration. Because again, if they don't have the ability to absorb the nutrients and the fluid that they need, then your patient is going to see significant issues. Diverticulitis, when you have a patient who has the weakening of the muscular walls, you've got to then get that pocket that forms. So it's kind of a hidden area in the colon, And when this happens, you get fecal matter that can become caught in the colon walls because the peristalsis isn't able to pull that matter out of the weakening of the wall, the weak area. Patients with diverticulitis will complain of fever, just a general overall malaise. So it's a general feeling of just not feeling great, body aches and chills. You know, it's not good to have fecal matter sitting in the walls of the colon. And then finally, hemorrhoids. And while we hope not to have a patient who calls 911 because their hemorrhoids are acting up, you can actually have a rupture. So hemorrhoids are created when there is swelling and inflammation of the blood vessels surrounding the rectum, and they will bulge externally, causes bright red blood during bowel movements, during defecation, and if one of those ruptures, it can cause bleeding. Cystitis, or a bladder infection, is very common. Many people will actually refer to it as a urinary tract infection, and it's caused by bacterial infection that sits in the urinary tract. If it's in the bladder, obviously that's when it tends to be called a bladder infection. It does become much more serious if that infection travels back up the ureters and into the kidneys. Your patients who have UTIs or who are likely going to be diagnosed with a bladder infection or a UTI are going to report an urgency and a frequency of urination, often complaining that it hurts when they pee or that they don't feel like they can empty their bladder when they pee. The kidneys play a major role in ensuring that our body is equal or has homeostasis. They're going to eliminate waste from blood. But when that fails, you're going to have what's called uremia. Uremia means that the waste product is remaining in the blood, which means that you are increasing the acidity of the blood. And know that one of the problems we'll see in the kidneys are kidney stones, and that's when you have calcium buildup that create blockages that crystallize in the kidneys. Acute kidney failure means that your patient has experienced a sudden decrease in their kidney function. When you have a patient with acute kidney failure, often because of kidney stones or because of infection, it is reversible when there is a prompt diagnosis and treatment. Patients with chronic kidney failure, it's irreversible. This is somebody who has had the progression of their kidney failure over a period of months or years. And as they get worse, as it continues to progress, they end up needing dialysis or a transplant eventually. You know, obviously, if it's chronic kidney failure, you're not going to reverse the damage. So eventually, once the kidneys reach a specific level, you're going to need a transplant of a kidney that is fully functioning. We do see many gynecologic problems in the females that result in acute abdominal pain. And any lower quadrant pain may relate to issues with the ovaries, the fallopian tubes, or the uterus. So it may just be that it is part of the menstrual period and they suffer from severe significant cramping. Could be it's ovarian cysts, or even that it's called a torsion of the fallopian tube, where it gets all twisted up and it isn't getting the blood flow. Some of the other things to consider with other organ systems in the abdominal cavity is the fact that the aorta lies immediately behind your peritoneum, that lining. And when you have a patient who has an abdominal aortic aneurysm, or a AAA as they like to refer to it, it is an aneurysm of the aorta in the abdominal cavity. And like we've already said in previous chapters, an aneurysm is the ballooning of the wall of the aorta because of weakening. The problem here is this is a significant vessel in a significant area of the body, and it will present as a pulsating mass in the abdomen when the patient is lying down. And you've got to be cautious, because where you want to go palpating the abdomen, if this is a pulsating mass and you palpate it, you could rupture the aneurysm. Then pneumonia can also cause ileus and abdominal pain. So you've got to make sure that you consider the impact there too. Hernias can occur. So hernias are defined as a protrusion of an organ or tissue through an opening in the body cavity where it doesn't belong. A lot of our common hernias are into the groin, down through the pelvis, and it doesn't always produce that noticeable mass or lump or bulge. And the concern we have here is the strangulation. So not of the full patient, but of that tissue. When it goes through that opening it's not supposed to go to, it may get constricted and blood flow may get cut off. So it causes pain. Often you'll hear about it happening after a patient has attempted to move something super heavy or use incorrect form. Some of the signs that it's a serious hernia or the reducible mass that's not reducible, pain and tenderness when palpated, and discoloration of the skin in the area of the hernia, all areas of concern. So how do we treat and assess our patients with acute abdominal pain? Well, we do it the exact same thing. We start with scene safety. Consider the fact that acute abdominal pain, if it's bleeding, that's internal, eventually it may become external. So you might need a little extra PPE. Remember that it may be that it's a medical call, but it could be the result of a traumatic injury. Your first impression of your patient may give you an idea that it's potentially a AAA. The smells and odors may tell you certain things as well. Then we've moved into our airway and our breathing, recognizing that when a patient has abdominal pain, they'll often change their respiratory rate and rhythm, mostly because shallow breaths won't move the diaphragm as much. So it's not causing movement of the abdominal muscles, which should help. We're going to look at circulation. If they're complaining about abdominal pain, ask about their bowels and if they've vomited, because if they've had intestinal bleeding, they may complain of bloody stools, which is a lower intestinal bleed, or they may complain of vomit that has blood in it, which is stomach or upper intestines. And make a transport decision. After you've done your pulse and your circulation and given them oxygen and opened their airway, is this a life threat? Does this appear to be uncontrolled pain or significant pain causing issues? Those are your high priority patients. If it's a discomfort, then okay, this could probably be somebody that you wait and kind of, low prioritize. Our sample history. Don't just ask what were you doing on E. Now ask, over the course of the last couple hours, the last couple of days, what has changed? Have they seen a change in their bathroom usage? Is there a weight loss? What about gas? And yeah, you're going to be asking these questions and you probably have never wanted to know these things, but they can give you an idea of what's happening. Are they retaining gas and fecal matter? Are there other signs and symptoms? Do they have a history of this? If so, how does it compare? When you're doing your secondary assessment, you're going to go ahead and palpate that abdomen. You want to give a focused physical exam of the abdominal cavity. Know that your normal abdomen is soft and not tender. So when you push on it, the patient shouldn't be in discomfort if it's normal. Pain and tenderness are a sign of abdominal issues. We don't just want to palpate, we want to visualize our abdomen so that we can see if there's any bruising or distension. We want to palpate gently, one quadrant at a time. If our patient says that their pain is in one specific area, then ask them to point to it with one finger and palpate that area last so that they aren't experiencing pain when you palpate the other areas. Get vital signs. Beyond the respiratory rate and the pulse rate, check the blood pressure. If there's an internal bleed and it's significant, the blood pressure may be indicative of a bigger problem. Reassess frequently. Treat these patients really as load and go because we can't see what's going on. We can only assume. Make sure you're checking your interventions, including treatment for shock in case there is that bleed. If this is some sort of issue with the female reproductive system, they may need some emotional support. Or if this is somebody who has experienced lots of problems, they may just be exhausted from fighting. Transport them in the most comfortable position. If they don't have a traumatic injury, that means they need their C-spine maintained. Consider transporting them, allowing them to have their knees drawn up to their chest, because that will relax the muscles of the abdominal cavity and the abdominal wall. We can't treat acute abdomen, so I can't make the organs better or fix the internal bleed. What I can do is treat for the signs and symptoms of shock, give them oxygen, and transport them to the hospital. Recognizing that there is a high probability that this could also be some type of infection, we're going to make sure we clean the hospital. We're going to make sure we clean the ambulance and the equipment that we used. Honestly, that should be in every call, but it is important here. If you've had a patient who is having dialysis emergencies, you may be picking them up from a dialysis center. They may have had a problem when in the middle of their dialysis. We've got to keep things in mind. So remember, the dialysis filters blood. It's cleaning the toxins out of the blood and returning the blood to the body. It does that outside of the body. So in dialysis, I'm removing blood, cleaning it in a machine, and then putting it back, all in a seamless process. If my patient hasn't been getting their dialysis, and we see this a lot during hurricanes and snowstorms or other weather events, pulmonary edema can occur because they've got that buildup of waste in the body. Remember that the dialysis machine is the kidney. The problems that exist when we have a patient on dialysis or a patient going through dialysis are pretty significant though. Hypotension, because obviously we're removing blood volume. Now, we are putting it back, but until it gets back, they've got low blood pressure. Muscle cramps. If it cleans too much, you're not getting everything that you need necessarily back. Nausea and vomiting. Hemorrhage from the access site, because these are two ports, both removing and replacing blood back into the body, and they're pretty large. And then infection, because anytime you introduce something from the outside world into the body, it's not going to be happy. How do we handle patients in dialysis emergencies? Well, ABCs. We're going to give high flow oxygen if it's indicated. We are going to control any external bleeding from the access site in the same way we would, which is direct pressure. We're going to sit them up. If there's pulmonary edema, if necessary, we will raise the legs, put them in a supine and Trendelenburg position. But again, pulmonary edema, they cannot lay flat. And we're going to transport them promptly.